Good morning. I'd like to go ahead and start grand rounds, and it's a real privilege for me to introduce my colleague, Dr. Kurrelmeyer, who's Associate Professor of Weill Cornell Medical College and Medical Director of our Methodist DeBakey Cardiology Associate Clinic, and recognized for her expertise in echocardiography, prevention and treatment of cardiovascular disease in women, and her has significant interest in diastolic heart failure. She completed her medical degree, obtained it in the University of Minnesota, followed by residency at Barnes in St. Louis and fellowship at Baylor, and has been on staff really over the past 15 years and has acquired a vast clinical experience that marries well with her clinical research interests. So we're delighted to hear about exploring pathophysiologic mechanisms in heart failure with preserved EF, and she has the privilege to introduce the panel, so we look forward to today's discussion.
Sure. Absolutely. So basically what I'll do with the panel is right after I'm done with my talk, I'll introduce the next speaker, and then she'll introduce the next speaker. So you won't forget our names right before we present. So let's just go on here. So I think we all know that heart failure affects a lot of people, nearly 5 million Americans, with 550,000 new cases diagnosed each year. It's the #1 discharge diagnosis in the United States, and accounts for over 3 million hospitalizations each year. 80% of those people are more than 65 years of age, and more than 50% of people living in the community with heart failure have heart failure with preserved EF. If we look at the epidemiology studies and registry studies, which are just retrospective studies of all consecutive patients hospitalized with heart failure whose ejection usually was determined using echocardiography over a specified time period, they're shown in this table, and there's more, but this was just the first few that were published. Basically, when you look at the baseline characteristics, you see that these people are old. They're more than 75 years of age. They're predominantly women. More than 2/3 of the time, they predominantly have hypertension, not as much coronary artery disease. They have more than a third have diabetes, more than a third have AFib. They have some renal insufficiency as shown by their baseline creatinine of 1.5. If we just look at that Olmsted County, the very first epidemiologic study that was published, when you compare those with heart failure with preserved EF to those with heart failure with reduced EF, again, you see that they are significantly older, they're significantly more likely to be women, they have significantly more hypertension, less coronary artery disease, similar amounts of diabetes, more atrial fibrillation, they have more anemia as demonstrated by a lower hemoglobin, similar degrees of baseline renal insufficiency, and they are more obese. When you look further in the study, then looked at the prevalence of heart failure with preserved EF over a 16-year time period starting at 1986. And basically, when you look at the percentage of patients hospitalized with heart failure with preserved EF, it was slowly increasing over that time period. When you compare it in the right-hand panel to those with reduced EF, you can see that it was slowly decreasing. And many people have theorized to why this occurs. I think it's a combination of an aging population, increasing prevalence of obesity, atrial fibrillation, hypertension, diabetes, and also improvements in non-invasive techniques in predominantly echocardiography to diagnose heart failure with preserved EF and increased awareness, and also improvements in treatment of coronary artery disease and other cardiovascular disease processes, which led to reductions in LVEF. If we look at the Kaplan-Meier survival curves for patients with heart failure with preserved EF and compare it to those with heart failure with reduced EF, basically what you see is in that up to that 1 year after that index hospitalization, there's no difference in the curve, so there's no difference in survival between the two groups. However, as the curves start to separate after 1 year, where the survival rate for patients with heart failure with preserved EF is better than those with reduced. And finally, when they took that 16-year time period and split it into time tertiles, with 1987 to 1991 being the oldest time tertile, which is shown by the black line, 1992 to 1996 shown by the red line, and 1997 to 2001 by the blue, what you can see in the top-hand panel is those with heart failure with reduced EF have had improved survival as time has progressed, which basically likely reflects all the evidence-based therapies that we have for patients with heart failure with reduced EF. If you look on the bottom-hand panel, that's patients with heart failure with preserved EF, and oops, sorry about that. And basically, you don't see any difference. So this is likely reflecting the fact that we don't have any evidence-based therapies for these patients. So the conclusion of these epidemiology studies is that heart failure with preserved EF is most prevalent among elderly women with hypertension, diabetes, or both, and often they have coronary disease and AFib. The survival rate and rehospitalization rates are similar up to 1 year after that index hospitalization event for patients with heart failure with reduced EF and heart failure with preserved EF. It's slightly higher survival rate, and rehospitalization rate is slightly lower in patients with heart failure with preserved EF more than 1 year out from that index hospitalization. Prognosis is improved only for patients with heart failure with reduced EF. However, the prevalence has increased for patients with heart failure with preserved EF, even though their rate of death has remained unchanged. And it was data like this that really underscored the importance of this huge growing health problem. So when we look at the clinical trials in heart failure with preserved EF, they're listed here in this table based on the drug, primary outcome, and the trial findings. You can see starting off with candesartan, that primary outcome was cardiovascular death or heart failure hospitalization. It was negative, but those patients who were treated with candesartan did have a reduction in heart failure hospitalizations, a significant reduction when compared to those not on candesartan. You can see that perindopril negative, digoxin negative, nebivolol negative, irbesartan negative, carvedilol negative. Spironolactone again had this combined primary outcome of CV mortality, aborted cardiac arrest, and heart failure hospitalization. Again, the primary was negative, but those people who were treated with spironolactone had a reduction in heart failure hospitalizations. Sildenafil negative, valsartan and the neprilysin inhibitor compared to valsartan alone, there was a very soft endpoint, which was change in NT-proBNP, and the combination therapy did show a reduction, which has led to Paragon-HF, which is still enrolling, and then it has the hard primary outcome of heart failure hospitalizations or heart failure mortality. We have serelaxin, which improved dyspnea but not heart failure hospitalizations. And finally, ivabradine, which did show improvements in peak VO2 and E over E prime after exercise, but that was just with 7 days of therapy. So let's go on to this next slide. So basically, the reason, many people have tried to hypothesize what the reason is for the failure of these clinical trials in patients with heart failure with preserved EF. And one of the most prominent theories is that perhaps mortality is not the best endpoint in this elderly population, since they die from multiple other non-cardiac causes which couldn't possibly be affected by the study drug. And maybe we should be looking for softer endpoints in this very old population, such as reduction in symptoms or reduction in heart failure hospitalizations, or improving their quality of life, which may be more important to this group of patients rather than mortality. And this is basically data from one of these studies, and basically you can see all the epidemiologic trials at the top and all the randomized clinical trials, controlled trials at the bottom. And what you see is that the people in these trials, 30 to 60% of the time, died from other things other than their cardiac disease. This has also been shown in a meta-analysis that looked at the overall pooled odds ratio for the risk of mortality in patients in all those different randomized clinical trials that were treated with ARBs and ACE inhibitors. And you can see that there was absolutely no benefit for RAAS inhibition on mortality. However, when you split it up and you looked at heart failure hospitalizations, you can see that there was a significant benefit for RAAS inhibition on heart failure hospitalizations. Another problem that people theorize that may have led to that negative endpoint in those clinical trials is that the diagnosis of the heart failure with preserved EF syndrome is very difficult. Initially in those trials, they just relied on clinical signs and symptoms of heart failure and evidence of preserved EF and echocardiography. As the trials progressed, we realized that we needed more high-risk patients, so either heart failure hospitalization or biomarkers were included. I think the trial that demonstrates the most that you really need really tight inclusion criteria to make sure that you enroll the correct patient is TOPCAT. And basically what happened in TOPCAT is that 50% of those patients were enrolled from the USA, Canada, Argentina, and Brazil. And in that trial, they had to have clinical signs and symptoms of heart failure, evidence of preserved EF, heart failure hospitalization, or elevated BNP, NT-proBNP. And those who were enrolled in the Americas actually were enrolled through that elevated BNP group. When they looked at their event rate, it was 27.3%. When they compared it to those who were enrolled in Eastern Europe, who were predominantly enrolled on the criteria of heart failure hospitalization, their event rate was just 9.3%. So it's really looked at how difficult, or demonstrates how difficult it is to actually pick out the patients with the heart failure with preserved EF syndrome and how it really affects the event rate in these clinical trials. Oh, sorry about that. And basically, there have been, therefore, several criteria proposed to define the heart failure syndrome in the recent 2013 heart failure guidelines. And basically, in the guidelines, it says, in addition to clinical signs and symptoms of heart failure, you also need evidence of preserved LVEF. You need evidence of abnormal LV diastolic dysfunction by Doppler echocardiography or cardiac catheterization, and you need to measure BNP or NT-BNP. On echocardiography now, we have multiple different parameters that we use to diagnose heart failure with preserved EF. Of course, we have the peak E on the mitral valve, mitral inflow velocity, and we combine that with the E prime. E over E prime is a good measure of LV fluid pressures, or correlates quite nicely with pulmonary capillary wedge pressure. We can also measure the LA strain, which is significantly reduced in people with heart failure with preserved EF compared to normal people. We can also measure the longitudinal systolic strain. Even though those people have preserved EF, their longitudinal systolic strain is significantly impaired. We can also measure their PA systolic pressures, because frequently these people have elevated pulmonary hypertension. In addition, we can measure markers of RV function, because frequently they also have subclinical RV dysfunction, and we can measure it using tissue Doppler imaging, specifically measuring the S prime, or we can measure the tricuspid annular plane systolic excursion, or TAPSE, on M-mode. So it has been proposed, because the syndrome is so difficult to diagnose, that and because the different comorbidities and the different types of heart disease that they have determines not only treatment but also prognosis, that patients with heart failure with preserved EF really should be separated into phenotypic classes. And that very first class, which is the garden variety heart failure preserved EF patients, which is that patient who's female, has hypertension, diabetes, obesity, those are the patients that really should be entered into this heart failure with preserved EF trial, because those really are the most predominant patients with this syndrome. All the other patients, those with coronary artery disease who then have heart failure with preserved EF, those with right heart failure who then have heart failure with preserved EF, AFib, heart failure with preserved EF, hypertrophic cardiomyopathy with heart failure with preserved EF, and valvular with heart failure preserved EF, and high output with heart failure with preserved EF. All of these, the focus should be on that other disease process that they have, and you should treat and support that other disease process. The final one, the rare causes of heart failure with preserved EF, which is your infiltrative cardiomyopathy, such as amyloidosis. Again, those patients really need to search for the underlying pathophysiology and enroll those in clinical trials specific for that underlying pathophysiology. When we focus on that garden variety heart failure with preserved EF patients, and if we look at them more closely, this is actually subset analysis from the CHARM preserved database. Basically what you see is that within that population, there are certain comorbidities that really worsen prognosis. So this is basically looking at those patients who are diabetic and compared to those patients who are not, and looking at, on the left-hand panel, the cumulative incidence of cardiovascular death or hospitalization due to heart failure and all-cause mortality. And you can see that those with diabetes do fare significantly worse when you look at these two outcomes. When you look at the right-hand panel, what they did is they then separated out those diabetics with ischemic heart disease and without ischemic heart disease. And what you can see with respect to cardiovascular death or hospitalization due to heart failure is that there really was no significant difference if you had ischemic heart disease, what really determined your prognosis was whether or not you had diabetes. When you look at all-cause mortality, again, those with diabetes and ischemic heart disease did worse. Those with diabetes only and no ischemic heart disease did the second worst, followed by those with ischemic heart disease, and of course those who did the best were those who had no diabetes or ischemic heart disease. When they looked at the risk of the different outcomes associated with diabetes and separated according to reduced EF and preserved EF, you can see that they're in pairs, and reduced EF is on the top and preserved EF is on the bottom. What they found was that diabetes is associated with increased risk of cardiovascular death, hospitalization due to heart failure, and all-cause mortality in both groups. But it was even a greater risk in those patients with heart failure with preserved EF. If we also look within this garden variety phenotypic class of heart failure with preserved EF, we also know that there are significant sex differences. And this was looking at adverse LV remodeling in men versus women. And what you can see here is that women have significantly more adverse LV remodeling. They have significantly more concentric remodeling, significantly more concentric hypertrophy, and also eccentric hypertrophy. When you look at their Doppler, they have more impaired LV relaxation as measured by a low E prime on the tissue Doppler. They have higher LV filling pressures measured by E over E prime on Doppler. They have greater LV diastolic and systolic stiffness. They have a higher EF, but they have a similar reduction in the global longitudinal systolic strain. And if you look at arterial stiffness, there really is no difference between the sexes when you adjust for the body surface area. So basically, obesity, hypertension, aging, and gender are associated with significant molecular myocardial changes and molecular dysfunction that contribute to this heart failure preserved EF pathophysiology. This can be best studied in animal models where comorbidities and confounding factors can be precisely controlled, and therefore new potential therapeutic strategies, the benefits of these can be more precisely determined. I'm now going to turn this talk over to Anisha Gupte. She's a research scientist with Dr. Dale Hamilton, and she is going to discuss this heart failure with preserved EF model that she's been characterizing. Thank you.
Thank you, Dr. Kurrelmeyer. So from her talk, we figured for one thing for sure that heart failure with preserved ejection fraction is very predominant in the elderly and the postmenopausal women, and we do not have very good treatment options at this point. So I'm going to talk about looking at preclinical modeling in using a mouse model for heart failure with preserved ejection fraction, which would potentially help us identify some of the underlying mechanisms and identify potential therapeutic targets, which are pretty important right now. I have nothing to disclose. Interestingly, it's very difficult to push mice into heart failure, but with Keith Euchre's help, we've been using L-NAME, which is a nitric oxide inhibitor, and angiotensin 2 to induce hypertension. And with this combination of the two drugs, within 5 weeks, we are able to see heart failure in male mice. So you're looking at data from male mice, and within 5 weeks, we have hypertension, hypertrophy as seen by the heart weight to tibia length ratios increasing with the treatment, depressed factorial shortening, and decreased ejection fractions. And depending on the age of the mice, it can go down to 25 and 30% ejection fraction. And we were able to characterize this model and understand some of the mechanisms, and we published that in these two papers down here. Now, when I started my independent research, I was always interested in the gender differences in heart disease. There's no denial in the fact that women and men present such different heart disease. And there seems to be an advantage in females, which gets lost with diabetes, metabolic syndrome, and menopause. And because of this association with menopause, that things change so dramatically after menopause, we tend to ask whether it is driven by estrogen. Now, after the Women's Health Initiative in the last decade, estrogen was totally thrown out of the window. But now, recently, many people are revisiting the data and asking whether the timing was right, whether estrogen plus progesterone was correct, whether we should be modulating individual estrogen receptors. And to get to the bottom of this controversy, we wanted to find a model which can sort of mimic the menopausal cardiac stress. So we went ahead and took female mice, just C57 black 6 mice, and gave them L-NAME and angiotensin 2 as per Keith's model. And this is just with ovarectomy. So what we do is to induce estrogen deficiency, we remove the ovaries, the main source of estrogen, and we find that there are huge metabolic effects on the mice. So when they're given a Western diet, which is pretty much what we eat every day, a high-calorie, high-fat, high-carb diet, the ovax mice, by the way, we in the mouse world call it ovarectomy and not oophorectomy, and we say ovax for short. And when given a Western diet, these ovax mice gain a lot of weight very quickly. These mice also accumulate most of their fat around in the visceral area, central adiposity, And when given an insulin tolerance test, they have a harder time disposing the glucose. And when we put them in a CLAMS unit to measure oxygen consumption and CO2 release over time, like the light and dark cycle, day and night cycles, we find that the OVAX mice are just having less energy expenditure. They take up less oxygen, release less CO2. And not surprisingly, when you put them on a treadmill, they get exhausted very quickly. They can't run very far. This is exactly how most postmenopausal women feel. So, here we have, a model where we are looking at loss of estrogen having huge metabolic impacts. So we would take it to the next level and give them the L-NAME and Ang2 to induce hypertension. And the hypothesis was that the OVAX would result in greater severity of L-NAME plus Ang2 induced heart failure. However, we had no changes in EFs. The EFs remained at 60%, and I was like, great, now my hypothesis is out of the window. However, we went on characterizing a little more. We looked at the echoes in more detail. We have the Vivo 2100, which is a state-of-the-art small animal echocardiography system. And we noticed that their internal diameters were smaller. The red bars show the OVAX mice given the L-NAME and Ang2. The volumes were smaller. And if you look at BNP expression, and BNP is a known marker of the cardiac stress, and it is increasing over time very significantly. So at this point, we went to Dr. Kurrelmeyer and what do we do next? And she suggested doing Doppler studies. And the Vivo 2100 has the capability of doing tissue and pulse Doppler. And what we found was that the E to A ratios were depressed in the sham mice treated with L-NAME and Ang2. However, they were even more depressed with the overectomy. The E to E prime ratios were increased in the sham mice with the treatment, and OVAX mice had even greater E to E prime ratios. Now, what causes these diastolic dysfunction? And one of the things is predominantly seen as the stiffer left ventricle, and fibrosis is thought to be one of the reasons underlying it. And indeed, we see a lot of fibrosis, more so in the OVAX mice, significantly greater than the sham mice who have estrogen. However, what is the trigger that leads to this fibrosis? There has to be something upstream of that, and we think it has an upstream metabolic impairment. We believe so because diastolic relaxation is an active ATP-dependent process. It doesn't consume as much ATP as a contraction process, but it requires a high level of ATP to be present there for the actin-myosin bond to break during relaxation. They've also shown that the creatine phosphate to ATP ratios, reflecting the balance of energy consumption and supply, is reduced in patients with heart failure with preserved ejection fraction. There are few studies in animal models studying diastolic dysfunction, and even fewer with females, and some of them have shown mitochondrial dysfunction. So we went ahead and examined what goes on at the level of the mitochondria in our mice. So this is looking at mitochondrial oxygen consumption using the seahorse technology. And we are essentially looking at this peak out here. The black bars are the sham mice having the largest amount of oxygen consumption. The OVAX mice have less oxygen consumption in green. The sham diastolic dysfunction mice have even less. And the OVAX mice in diastolic dysfunction have the least oxygen consumption. So they are not functioning optimally. And not only that, they're actually producing a lot more reactive oxygen species. So if you look at the blue bars are the sham mice in diastolic dysfunction, and the OVAX mice in red have even greater reactive oxygen species production. And if you look at the electron micrographs of the heart tissue from these mice, we notice that there are a lot more dying mitochondria, abnormal looking mitochondria, even lipid droplets in the OVAX mice. So there seems to be mitochondrial dysfunction, and then the obvious question is, why isn't contraction affected if there is mitochondrial dysfunction, right? However, if we put the male mice on this graph, you're looking at the male mice having a major mitochondrial dysfunction. their graph would come somewhere here. So we're looking at still a moderate mitochondrial dysfunction with more like an inefficient mitochondrial system that produces more reactive oxygen species. What we think is happening is that small decreases in mitochondrial ATP production actually affects diastolic relaxation first, because diastolic relaxation actually requires that high level of ATP for that actin-myosin bond to break, so the small changes would have a more profound impact. When there are larger changes, the contraction gets affected as well. So to test this, we did the ion optics microscopy, which essentially measures the sarcomere length of each individual cardiomyocyte over the contraction and relaxation period. And these are the control cardiomyocytes. These are individual cardiomyocytes. And the contraction and relaxation are shown here, quantified here. If you give oligomycin, which is an inhibitor of ATP synthesis, and you give it in a really, really low dose of 1 nanomolar, you see that the contraction is maintained, the amplitude is same as the control, but the relaxation starts delaying. And this looks very similar to the OX mice in diastolic dysfunction, where the relaxation is decreased, where this contraction is maintained. Anything more than 1 nanomolar of oligomycin to inhibit ATP synthesis affects the contraction. You'll see much less contraction going on. Dr. Kurrelmeyer mentioned that having diabetes really worsens the prognosis. So to test that, we actually gave these mice a high-fat diet in combination with the L-NAME and Ang2. And we find that the mice that were on chow diet is similar to what you've seen before, but the high-fat diet fed mice fared even worse. Their E2E primes were even higher, LB strains were changed, and the fibrosis was even more in these high-fat fed mice. So lastly, we decided we want to know which estrogen receptor. Is it both ER alpha, ER beta, and then there is this new receptor identified, it's called GPER1, which is more non-genomic in nature. Which of the 3 receptors is actually responsible for this? Do we just give estrogen, or should we actually try to activate one versus the other? So we gave the mice PPT, which is an ER alpha agonist, DPN an ER beta agonist, and G1 a GPER1 agonist. And we see that the BNP expression was reduced with, of course, estrogen, PPT, and G1. We followed up with the PPT because we've done studies that actually show more metabolic effects of the ER alpha activation. And we find that just on a high-fat diet, when these mice are given PPT, they're completely resistant to weight gain. Again, that would be my dream, right? Keep eating but not gain any weight there. And then their energy expenditure was also much higher. And in terms of diastolic function, the fibrosis was reduced. E to A ratios were brought back to 1.5, and E to E prime ratios were reduced. So there is some hope in understanding how we could use PPT or an ER alpha agonist. It would be important to have an agonist which is tissue specific. You don't want any reproductive or carcinogenic, oncogenic effects on this. So summarizing, we hypothesize this metabolic mechanism. We know that there is fibrosis, a stiff left ventricle, and delayed cardiomyocyte relaxation that leads to diastolic dysfunction. So we're trying to identify these upstream mechanisms that lead to it. We think that loss of estrogen signaling actually abolishes signaling through NERF1. NERF1 is a transcription factor that's very important in regulating mitochondrial function. We chose to study NERF1 because NERF1 has been shown to have an estrogen response element on its promoter, so estrogen can activate NERF1 to regulate mitochondrial function. We think with loss of this, the mitochondria function very inefficiently, creating a lot of oxidative stress. There's moderate reduction in ATP synthesis that delays cardiomyocyte relaxation, And the oxidative stress triggers pathways of fibrosis generation, and both together lead to diastolic dysfunction. So we are testing each of these with either agonist or knockout studies. And this is all possible with this great team that we have. And Dr. Shuman Lee has been responsible for most of our Doppler and echo studies. And Dr. Kurrelmeyer has been advising us on this project. With that, I'd like to introduce the next speaker, the boss, Dr. Dale Hamilton. A decade ago, he rekindled his interest in research and molecular biology research, and since 2013, we have the Center for Bioenergetics and a great team to support it, and he's going to talk about possible therapies.
No disclosures to make, and this is kind of an example of seeing a clinical problem. Year and a half ago, Anisha and I began to talk about this. She talked me into the Ovex mice, looking at that rather than studying these male mice, and we get these type of results. This is a slide that she had shown, where there's all these metabolic effects, not only in the heart, but just generally in the whole body, that are resulting in weight gain in the central area. We did MRIs and body fat analysis on them, and a pre-diabetes state, and so forth. So it got my attention. It happened so quickly. I mean, these mice gained the weight just in a few weeks, eating the same chow. I mean, we measured it, kept them as controlled, paired diets, and lost their exercise tolerance. So we then decided to go and the work that Anisha's done to look at this metabolically. What I'd like to do now, though, is kind of bring it back to what started this, and a problem that we see a lot, at least in endocrine practices and in primary care practices. I don't know at this point if it gets to the cardiology much. And it's an area that, rather than waiting until there's fulminant heart failure, addressing this earlier. And this, just as an example, is data from a case, and it's very typical of what we might see in an endocrine practice, 47-year-old. And I've circled the things that are the problem here: perimenopausal, starting to gain weight, central abdominal area, blood pressure going up, and BMI is 27. And it's in the waist area, 34-inch waist. She has laboratory studies here that show that she does not have diabetes, but it's a pre-diabetes state. Fasting glucose is in excess of 100. But the insulin level is, quote, normal at 12. But if you have an insulin level of 12, your blood sugar should be 76, not 100 or more. So she has mild insulin resistance. And complaining of shortness of breath, traveling with her husband, walking through the airport, getting short of breath, having trouble carrying a conversation. No complaint from him, mind you. Or walking upstairs, feeling short of breath. Subtle symptoms. She's not in heart failure. Her exercise tolerance is down, just walking around the neighborhood. So I ordered an echo, and a typical echo, if we order it, we get EF and LA volume 52. Nothing too striking, although to me I see that left atrial volume as kind of being like the A1C to ventricular stiffness. In other words, it kind of integrates it and it gets larger and larger as that ventricle gets stiffer. But if we correct that for her BSA, which is not done on the regular report, you can see her BSA is almost 2. It's going to correct out to about 26 ml per meter squared body surface area, which would be normal. So here's an individual that, in my mind, is heading for problems. And this is why we took it to the bench and we're trying to develop a model to try to understand why. And the usual recommendations are lose weight, exercise more, and maybe consider an antihypertensive and you send them home. We'll come back later. But what's lacking here is any discussion of, it's called MHT now instead of EHT, menopausal hormonal therapy, or diabetes prevention, addressing the insulin resistance, CV risk prevention, statin use, aspirin. These are usually not discussions carried on at this point in many practices. So what happens, individual, now we're 5 years later, and things have progressed. She's put on some more weight, the blood pressure's higher, and the insulin resistance has progressed. In the EF, now the left atrial volume's at 52, but since she's gained weight, her body surface area has increased, and it still corrects out to 26, so it's technically normal. And the dyspnea with exertion is not getting any better. Again, there might be things that we could do at this point to stop what's inevitably going to happen here. And maybe the ER alpha, might be something to consider, or there's other therapies. But the whole purpose of taking this back to the bench, as we've done with our mouse model, and is to try to look at a way to maybe bring this back to the clinic if we can understand the underlying pathophysiology, and in particular, look at maybe the role of estrogen. And the use of estrogen is undergoing a completely new reassessment here, and there's been some recent standards. Endocrine Society just at the end of last year published some new recommendations, with the message being that you should use it unless there's a reason you should not in women that are perimenopausal or undergoing menopause. I mean, it's a complete turnaround from what we used to do. And the reasons not to, of course, would be breast cancer risk, or if they have established coronary artery disease or ischemic heart disease, to not use it then. Or if they've been more than, they say 10 years, some people say 5 years, without estrogen, it may not be beneficial to then begin it. So there's been a complete rethinking of this, of the use of estrogens. So one, in that first case, when she's 47, or even in the latter case, one might then consider, in addition to just exercise and eat less food, lifestyle modification, nutrition, weight control, regular exercise, and favor the use of estrogen, and maybe an ER alpha agonist or some other component. These are things we hope to sort out and nuance. And metformin to fight the insulin resistance, even though she does not have diabetes at that point. TZDs, thiazidines, pioglitazone, for example, rosiglitazone, question mark. They have tremendous benefit early on, but they can lead to heart failure, so they're questionable. And set some goals and do short-term follow-up. So if we turn the clock forward now 10 years, and this one I kind of just progressed just from what we see clinically, so not from this one patient. We haven't moved that far with her yet. Now has diabetes and shortness of breath. The symptoms are still there. Her EF is preserved 50%, but now the atrial volume's at 65, and when you adjust it for her body surface area, it's at 30. Has hypertension, type 2 diabetes with impaired insulin action. Her HOMA number, it's a number we use in the clinic a lot, but you can calculate it from the insulin glucose, to see if insulin action is normal or not. And normal is under 2, and she's at 4.4. So aggressive measures to reduce that action might help systemically and possibly help metabolically. So, and these are conditions in her, just to summarize what we're seeing. And the strategy would be for glucose control, beta cell preservation, and weight reduction. That, in my world, that's what we would like to see and where we'd like to go with this. And therapies besides the TZDs and insulin, which is going to promote more weight gain, would be to use these DPP-4 inhibitors, such as sitagliptin or Januvia, and there's several of them available. There were 3 early trials here that I've summarized. One of them I was a side PI on the Examine trial here. They have had a question whether they contribute to heart failure or not. But last week, or 2 weeks ago now, this C-Notes trial came out in New England, and they did it looking at that as a primary outcome, and they seemed to clear it as a safe for cardiovascular outcomes. These are the oral DPP-4 Januvia-like medications. But going beyond that, because those are really kind of a mild treatment, injectable incretins such as Byetta, these have been out a long time, now approved for weight reduction and metabolic benefit in individuals that do not have diabetes, at least with Victoza. And there's incretin or GLP-1 receptors on the myocardium that may improve glucose utilization and myocardial function in these individuals. On the other hand, this whole second class here, the SGLT inhibitors, these sodium glucose cotransporters that are blocked in the kidney, so you urinate out the glucose, blood glucose goes down, you're losing calories and you lose weight, may not be beneficial to the heart. It's not been looked at, but we have SGLT1 and 2 inhibit transporters on the heart that allow glucose to enter. And if we block that, then it may impair the metabolic findings, or metabolic function of the heart. And then there's other compounds here that we're going to look at in our mouse model. So our clinical objective in this is to bring it back to a clinic and identify it early, maybe looking closer and at echoes and what we're reporting on echoes. Maybe we should have E-day ratios or E to E prime and these things in these individuals with these symptoms and be more aggressive early on. Metabolic imaging is an area that we're have looked at now in the mouse model, and what we're finding is that when there's diastolic dysfunction, when the heart's under stress, instead of switching to glucose, which is our preferred fuel, it's switching to fats. And this would be precision medicine at its best in my mind. Instead of looking at genes, looking at metabolism, cardiac metabolism. And if you see an individual comparing PET FDG to PET C11 palmitate, that they're either utilizing glucose or utilizing fats, we could then offer metabolic therapy. This is what we found on our mouse model, taking these mice and generating the C11 in our own cyclotron. It has a half-life of about 10 or 15 minutes, so somebody needs to be holding the elevator so we can get it up to the small animal PET in time before it loses all its activity. And we quantitate the palmitate uptake in the heart of these OVEX mice and control mice and compare it to glucose uptake using FDG. And you can see that when the heart is stressed, instead of switching, this should be going down, and the glucose utilization should be going up. It's not. They're switching to using more fat. It's like a diesel fuel instead of a high octane fuel to the heart. And if we could make a therapeutic intervention to switch it back, maybe with these incretins that I mentioned, exenatide or liraglutide, or other therapies, or ER alpha, estrogen, to switch back to a cleaner fuel to use, so to speak. And we did some gene studies here to show that this is a fat transporter, that it had gone up, and this inhibits glucose oxidation, and it had gone up. So we have a problem, a big clinical problem. Women going through menopause, getting this garden variety diastolic dysfunction, they're not in heart failure, but it's affecting their life, and it's not limited to the heart, but their whole body. We've been able to take it now to a clinical model, and we're getting close to where we can bring it back, and we're working on this IRB protocol where we want to, and I presented this to the OBGYN group in one of their grand rounds, and have talked to them about recruiting women that are having elective oophorectomy. So they're going to where they have estrogen at the age of 44 or less, and after the surgery not having estrogen. So a little bit like our mouse model as a start. And doing blood studies and so forth to look at insulin sensitivity, and then doing these C11 palmitate and FDG PETs to look to see if there's a change in cardiac substrate utilization, muscle biopsies to look at their mitochondrial metabolism. And then, from there, once we have that baseline, going to where looking at agents like incretins or ER alpha, if we could get one that's available for clinical use, at least in a phase 1 trial. Anyway, so this is kind of an example of where our team has taken what we see in endocrine field as a major clinical problem to the lab, sorting out the molecular mechanisms. And now we're getting close to where we can bring it back. We've got a team that Anisha had talked about. We've had support from a variety of sources, but I must admit the foundation here has been very supportive on some of this, especially the wives of some of our donors can really identify with this problem. So that kind of funding has been very helpful to allow us, without industry helping to steer it, to do this objectively. There's a picture of our team. So Anisha here, and Ajin, and Jesse, and Schumann. Anyway, that's the next talk. Anyway, so this is an example of what we see as a clinical problem. It may not hit your tables yet until they get further along, coming to the lab and then back.
Hamilton, Dr. Gupte, thank you for a very nice overview, and congratulations for putting the group together and tackling a very challenging and in a lot of ways complex problem. We have time for questions, so let's jump right in.
Two questions, clinical and then basic science. We'll start with Karla. Yeah, I think it's a very intriguing topic, and congratulate you guys for the breakthroughs. We're struggling with diagnosis, we're struggling with pathophysiology. But Karla, from the context of diagnosing these patients, I think the diastolic dysfunction by echo, the EF cutoff, has always been a challenge in being specific. What's the consensus or push towards more specific hemodynamic exercise testing for diagnosis of these patients? Because a lot of times it's exercise intolerance. For example, there are studies showing this peak increase in their wedge on minimal exertion in these patients is much more specific to diagnose their symptoms versus just resting wedge. So is there any consensus from the invasive diagnostic testing?
Well, in that regard, I think that it's quite clear when you talk to people, look in the literature, that there are two groups. There's the one group that actually is volume overloaded. They have the heart failure preserved EF phenotype just at rest, right? And then there's the other group that looks like if you were to echo them at rest, they have diastolic dysfunction. But you're right, if you put them on the treadmill, they just can't, they just can't augment, and they develop increased wedge, and they develop increased E over E prime. So there really are two groups. I'll tell you that that second group that you talked about, the one that has symptoms on exertion, is a very difficult group to target for any sort of treatment whatsoever, because they're already starting with a pretty much fixed cardiac output and lower cardiac output. There isn't really much that you can do for that group. And that's the group that stays on the outpatient side, and they're miserable every single time they come to see me because they get short of breath when they exercise, and there's no way that you can improve it because all of their comorbidities are controlled. And there's nothing, they are not volume overloaded, and there's not much that you can do for those people other than send them to cardiac rehab and try and improve other parts of that exercise physiology. I don't know if that completely answered your question, but I'll let you go on to part two.
No, I think that makes sense. I think we're still struggling as a community to define that subset of what we can do to identify these patients, and all the patients are so mixed up in weighing in the context of presentation. It's dyspnea explains. So that explains. Dr. Hamilton and Anisha, and pathophysiology of HFPEF has, I think we're just beginning to scratch the surface of understanding what's happening in the myocardium. One of the challenges that I always felt was we've historically viewed heart failure as cardiomyocytes, but probably the cardiomyocytes are bystanders of non-cardiomyocyte mechanisms leading to fibrosis and impact of it. And so the question to you is, and again we've talked about some of the work we're doing physiology of women, is there a difference by the lack of a Y chromosome in these non-cardiomyocytes in the way they respond to stress, causing either more fibrosis or causing more impact on the heart, leading to pathology?
Very good question. About whether the cardiomyocyte is a bystander or source of this. And I guess we, or I am anyway, looking at this as a metabolic disorder, that by the time you see it, fibrosis is clearly present. But early on, 47-year-old that I presented, I think it's a cardiomyocyte problem and an energy-related problem, and they're producing these reactive oxygen species that are then triggering the fibrosis, so that the heart is getting progressively stiffer. And now, what the role of the Y or the X chromosomes are on these, we don't know. We've not looked at that, but it's clear that estrogen, and we haven't looked at testosterone, what effect it would have. It may be help it, I don't know, but estrogen clearly is a player here.
Interestingly, the testosterone part, we were at one point hypothesizing that whether we can push these women into systolic heart failure with testosterone, and we gave these mice, we don't know how much testosterone to give a female mouse, so it was a little overboard, but we had, out of 3 mice, 2 mice developed systolic heart failure, the ES dropped. So there is a combination of, all these hormones working together and being messed up in the whole metabolic scenario.
First, I'd like to congratulate the whole team for the work you're doing. I think this is really very important work. And a lot of the findings you are observing make sense in terms of what we observe in the health. So I think you're in the right track. Couple of comments. First, I would be a little bit against grouping patients because I think we have a continuum here, and we see people evolve from one to the other. Sometimes when we group, we create our own fixed things, and it limits our ability to sort of move forward and think more about pathophysiology. That's just a general comment. In answer to your question, I think it's both. There is not a single patient with diastolic heart failure, even in the early phases, in whom you do not demonstrate impaired relaxation. So no question about it, impaired relaxation is universal, and that takes to your answer. By the time they get pretty sick, they usually have also stiffness and fibrosis. So again, you're in the right track of trying to figure out the timetable of things, but both clearly are ultimately present. Now my question, okay? Clinically, we see a lot of the things you have said. We also see a lot of very healthy elderly ladies, like my mother and grandmother, who died in the 90s and never had any heart failure. So clearly, genes play a role. And the question is, parallel to the work you're doing, what is going on in the genomic arena to also help us understand this better? Because there are many women who do just great, go through menopause, may even get a little hypertension, and still live into their 90s, don't develop any heart failure. So no doubt that genes play a role. What's going on? What's the current thinking? What's the current work being done in that area?
Great question. So my take on this is just removal of estrogen, losing estrogen is not the only thing. There seems to be a second hit that pushes them into diastolic dysfunction. And that is determined by lifestyle, obesity, all the metabolic syndrome, and that is also determined by the genes. So there's no consensus as what gene is actually determining it, but I think it's a metabolic second hit that pushes these women into diastolic dysfunction.
Yeah, I would agree. Rather than being a specific gene, one has not been identified. It's a problem that has emerged in the last couple of decades. That this double hit, that's what we're working on our mouse model of having something like mild insulin resistance. Might not be diabetes, but impaired substrate utilization. and then you change the estrogen and testosterone balance. And the double hit is what is affecting these cardiomyocytes and causing the ROS production.
So about 3 years ago, myself together with a bunch of Vero faculty and other faculties, I was not there at the time, but I mean, we were all invited to participate in a research study Vero was doing. And they grabbed our blood and they did our medical genome. This is not that expensive anymore. Is anybody doing that type of work with these kind of patients? Because I know it's like a fishing expedition, but all these things start as fishing expeditions. And nowadays, doing a medical genome in patients is really not that expensive anymore. Anyone doing that? Anybody working on that?
I'm not aware of human studies, but these mice, we did microarray studies to identify the genomic changes. And most of these genes were actually metabolic genes that were, again, substrate utilization and, of course, the effector genes that regulate fibrosis and stiffness. So I think that's a great idea to follow it up and on a human study to do more genetic characterization.
Yeah, in a couple of publications, we've done complete gene arrays and looked at it. It's mostly metabolic genes, but we don't know if it's what's coming first. Is this a response to the double hit, or is it causing the double hit? And human studies, there's so many genes, and they publish several thousand genes, and maybe 200 or 300 of them are up and 200 or 300 down. It's really hard to interpret that data and apply it to the clinical situation.
I too like to thank you for a really great discussion and being somebody who can identify with some of those features. I really appreciate all the work that's being done.
We've talked about it.
One of the elements that really intrigues me is your discussion about mitochondrial dysfunction. Certainly in the left ventricular side, that is something that under active research, but also we've done some work on that in the pulmonary hypertension and impact on the RV. And the mitochondrial disarray and dysfunction and fibrosis and all the subsequent elements, at least from that. I guess my question is, are there any potential targets for treatment based on that potential pathophysiology? And also the mechanism of the LV-RV interaction pertaining to specifically this kind of early diastolic dysfunction type of patients?
Yeah. Of course, in the RV and LV are two different beasts, so to speak. And we just published a paper recently, and I think you're aware of it. We talked about we isolated mitochondria from failing right ventricles, compared them to non-failing left ventricles. Individuals that undergone heart-lung transplants and with preserved LV function, showing that there's dysfunction there. But in terms of coming back and treating it, maybe with NERF1 gene therapy or mitochondrial-based therapies, there are not any. There are several we use in animal models, but they're not safe for human studies yet. But that could be where it's going. But we're thinking the mitochondrial problems are secondary to, in my case, I'm thinking to the metabolic problem, but it might be a gene problem, it might be fibrosis, but I'm thinking it's the mitochondria are victims. They can come back quickly. I mean, they have survived since we came out of the oceans, and they have a way of surviving. They're very adaptive to almost any environment.
So do you think they're more the bystander, not the initial?
I think they're a victim of it. And we have one side project going. We're looking at mitochondrial transplants, where we're isolating mitochondria, say from a normal muscle, and then putting it back into a cell culture to see if we can improve the metabolism of those cells. And it does. So maybe we'll come, instead of doing a heart transplant, we'll just do a mitochondrial transplant.
Did early, did early.
Yeah, thank you very much for this great discussion. So, as somebody interested in pulmonary hypertension, one of the phenotypes of diastolic dysfunction obviously is patients with pulmonary hypertension, and the things that you guys are doing, especially with the lack of estrogen and addition of obesity, both of them, I think the two-hit hypothesis really fits well with PH as well. So my question was, did you, look into the RV, and did you measure any PA pressures in your mice?
We need your help to do that.
Well, especially because I feel, one of the major pathways is, the TGF-beta pathway, which again, works through PPAR, AR gamma, and both your oophorectomy and obesity, both of them affect the pathway. So I think it'll be really interesting to look at it. So yeah, no, we should talk.
It's a technical challenge. I mean, these are hearts beating 500 times a minute.
Right, so we have a
chambers
system
are so
in our
small.
lab to measure, RV pressures, which we've been doing, so happy to.
Oh, great session, thank you. And I congratulate,
A surgeon speaks now.
Be on radar now.
But when you look at the heart, it's beating normally, so why would you have any interest?
Some years ago, we studied a large group of patients undergoing coronary bypass and categorized them simply by normal, diabetic, non-insulin dependent, and diabetic dependent. I know you're familiar with the paper. And we found very significant differences in the outcome in the three groups. So I'm wondering whether any of your research points to whether in the diabetic group, whether the onset of need for insulin correlates with any other parameters in terms of your lab work and your clinical work. And then we've mentioned cardiac fibrosis many times during the session. I'm wondering whether there's any role for routine cardiac MRI in these patients with both quantifying objectively the extent of fibrosis and the distribution of the fibrosis, whether maybe it's all in the septum or maybe it's free wall, to see whether that correlates.
Yeah, with regard to the latter question, early diagnosis is a big problem on this, and I think, and I've talked to people that do the echoes, and unless we specifically request certain ratios of this or that, we don't know. We just get the volume, and then MR would be great. If we suspect an individual, if we could do that and get insurance approval for it, it would really help us, because if there's fibrosis present, we're going to be much more aggressive. I think with the therapies we're going to be looking at, aggressive incretin-based therapies or hormonal or whatever, if we knew the extent of the fibrosis, the location of it, and so forth, it would change our therapeutic regimen. We have to get away from just saying, oh, just lose some weight and walk more. It's, it's just lifestyle. But things are happening over time. With that, the relationship with the diabetes, insulin resistance is playing a role, and the relationship with diabetes just makes it worse. But we don't know the temporal sequence of these things. I don't think, unless you've done work looking at temporal sequence, but that would be something very interesting to look at. But we think it's setting the stage.
The MRI is extremely sensitive, and they could just open up a new field looking at the papillary muscles of people with mitral valve disease. Extraordinary amount of information to be contained in these people, and we can see within the papillary muscle patterns of fibrosis with the MRI, so it's extremely sensitive test.
Yeah. Now that you bring that up.
Right on. So the difference is MRI has been great for scar type fibrosis. This is more interstitial sorrow. So it's not wait. It's not only recently that the software has been developed to actually look at that, and in fact, you are right on, and this is one of the areas that DeBakey is going to start concentrating in. It just took a little longer because it's not your classic, typical, patchy or scar type fibrosis. It's a lot more subtle, so it requires a little bit more tweaking of the software. They have it, and it's one of the areas we're going to be actually investing in Paramount. So you're right on. Yeah.
Well, thank you.
In thinking about that, we might want to include MRs in this study, where instead not just do the PET, metabolic PET imaging, but include MRs with and without estrogen, just to see if we can pick up early fibrosis or not. I've talked to DeBakey.
All right, great.